What's going on, everyone? This is going to be the week 2 recording for OB of our exam 3 content. If you would go ahead and sign in using this QR code. I'm actually just going to be keeping the PowerPoint open this week so you guys can see it. Alrighty, I think that's good. We're going to be going over just the first 50 slides of this PowerPoint over normal newborn. Okay, within the initial period of stabilization, we're going to be talking about obviously warm, dry, and stimulate. We're going to be doing we're going to be drying them because we don't want to be having evaporation, and that could lead to temperature loss. If needed, we're going to have positive pressure ventilation with an ambu bag. We are going to be doing the ventilation rate at a 1 to 3 if needed. But a lot of this stuff, when it comes to, the actual, providing oxygen and things like that, I'll be going over again within our high-risk neonate. We're going to be looking at pulse. We're going to be talking about the Abgard on this next slide. But when it comes to our umbilical cord, I would say as a nursing student, to use that whenever you're assessing their pulse. You can actually kind of be able to see it. You'll be shocked to hear that the pulse of the newborn is just really, really high. So yeah, when it comes to our initial assessment, if that heart rate is less than 60, we're going to be doing compressions. If it's more than 60, but between that 60 and 100 range, we're going to be doing that positive pressure ventilation. Okay. When we have our Abgard here, we've already talked about this a lot, but when it comes to our priority here, the initial assessment at 1 and 5 minutes, if the Abgard's 6 or less in 1 minute or 7 or less at 5 minutes, this neonate is not having that satisfaction. The transition is just not going well until the what's called extrauterine life, and it's going to require a lot of interventions and a lot of careful monitoring. Yeah, it says here, once the breathing has been established, you're going to check the heart rate. If it's less than 60 or 60 to 80 and not increasing, we're going to be doing cardiac compressions. The lower third of the sternum should be compressed with 2 fingertips or 2 thumbs at rates of 100 compressions per minute and a 3-to-1 ratio of compressions to assisted ventilation. When it comes to the Abgard, I would talk about use your book, use an example. This Abgard definitely will be a potential question, and I'll try to find some that can kind of replicate that. Of course, when it comes to the cyanosis, within that first day, you could have an Abgard of 9 because of the extremities may not be all the way completely pink. A lot of these can really go into one category, and I would say it falls into respiratory. If you're having a vigorous cry and a good cry, that is a large point of that as well. Okay, we're going to be putting mom on baby's chest to establish that warm barrier to the baby. The air that's around us when we're in the hospital room is very cold, and we have to make sure that we're putting them skin to skin or putting them in a swaddle to keep them warm. We're placing them on a warmer. We're going to be cutting the cord course, doing all this Abgard here. We have two meds here, erythromycin for eye prophylaxis and aquamaphytin. And please remember this here. Aquamaphytin is going to be a very important word because a lot of students may only write it down on their spirals as being vitamin K, but you never know. On a test question, she could give you this, and I mean, just be able to memorize that. Know that we're not giving anything in the gluteal. We're using vastus lateralis. Okay, when it comes to the assessment, we're really looking to observe their transition overall. When it comes to the temperature, that goes into many categories of potential sepsis and things like that. But pretty much what this rest of these slides here are going to go, we're going to break it down by system and talk about the normal findings and things that you're going to be looking for as well. Alrighty, so when we have a fluid to air environment, think about a fish. They're going into the air. They're getting exposed to the oxygen around them. With a fish and a mammal. While in utero, these lungs are filled with fluid. And of course, we're having all these different adaptations that are going to be happening upon going into extrauterine life. We do have the breathing movements here. I would say to kind of bring this together, when that baby goes through the canal, it's being compressed, and that is allowing all of that fluid to kind of venture out. That's why it says here on the bottom, with a C-section, they may have a risk for additional breathing support being needed because the fluid wasn't pushed out through the birth canal itself. So during birth, fluid is moved out of the lungs as the fetus passes through the birth canal. The chest, really, that compression of shrinking down is a compression. And when the trunk is delivered, the recoil of the chest initiates a negative lung pressure, leading to the passive first inhalation and air starts, replacing that fluid in the lungs. So whenever we're having that cry of that large breath, they're really gasping for air in that moment. Okay, with the first exhale, shifting to positive pressure in the lungs, now more movement of the air goes through the alveoli, able to be absorbed and allowing oxygen to go into the capillaries. And then, of course, the downward movement of the diaphragm pulls in that second inhale. While this is going on, the alveolar air volume increases, leading to increased pulmonary blood flow, and it's able to pick up absorbed fluids more and more. Sorry guys, I'm kind of sick. Alright, when we're talking surfactant and alveoli, lungs produce a cell called surfactant, which functions to maintain alveolar function by keeping the alveoli open and preventing the lungs from collapsing. This really goes into stuff we've talked about through the entire semester. If a fetus doesn't have any surfactant, before that certain weeks, if you have a very preterm infant, that surfactant's not really there. So the lungs are very much going to be immature. The main time of production with this is 28 through 32 weeks. And we're wanting to try to make it past 32 weeks, but if delivery is warranted or if their just preterm is imminent, we're going to give that baby steroids to encourage lung development. That's going to be celestone, also called betamethasone. Synthetic surfactant can be given. Our diabetic babies, that can really lead to it can withdraw that surfactant from being made in the body. And the main difference between a term baby and a preemie is the presence of surfactant itself. So that goes into here. Alrighty. Respiratory stimuli, cord clamping. Cord clamping, the cord is clamped, stopping the flow of oxygen into blood from mom, increasing the CO2, decreasing the pH, and decreasing the PO2. The stimulation of gasps, think of coming up from underwater. And even as humans, adults, no matter what the temperature is, it could be 75 degrees outside. When that water is warm and you're getting out of that water, you take a big breath and that chills hits you. Think about what else could be causing asphyxia of the fetus. Maybe they have a cord prolapse. Maybe they have any placenta issues, placental abruption, cord compression. If the cord is not clamped, placenta will deliver normally. Same process will happen. We have to make sure the clamp is in place and all the extremities are out of the way. Clamp it as close to the umbilical cord whenever the pulsation stops and mom is still having contractions. This allows to get as much oxygen-rich blood as possible, and a delayed cord clamp would increase the risk of jaundice when it comes to the breakdown of the blood. When it comes to temperature, the cold temperature stimulates the breathing center. Mom's stomach to room temp is a shock. When it comes to sensory stimulation, we're using light. There's lots of lights in the room. A lot of people are touching. There's lots of different sounds. That definitely does encourage breathing. Suctioning. If suction is needed, it's using a bulb syringe, and it really does look kind of like the shape of a light bulb. This is only if indicated. It's used to get that fluids out of there. Gastric suctioning can be used if meconium aspiration in the stomach. We're going to be squeezing it before we're putting it in, and kind of inserting in, and then you're going to kind of release, and that's going to be able to suction. Alrighty, we're going to be going into fetal circulation, and this is a pretty big category, and I really think that if you can kind of be able to understand this, that the pediatric nursing of heart defects will get a lot easier. So just focus on it now. To kind of bring it all together, though, within cardiovascular, the expansion of the lungs with that first breath increases pulmonary blood flow and decreases pulmonary vascular resistance. Kind of how whenever we're talking about fetal circulation and it's, what was there in the intrauterine life, there was all this resistance at the lungs, that we're really preventing the oxygen to kind of really go there. So a lot of these adaptations that are there are going to be closing. Okay. We have the foraminal valve right here, and I'll kind of zoom it in. Remember, the foraminal valley is between the left and right atria. This was that opening that, was able to kind of connect blood flow. And it was that fetal adaptation. This will functionally close in about 1 to 2 hours, and it'll anatomically close in a few weeks to 1 year. This will happen due to an increase in left atrial pressure. Some shunting may occur early in that transition, and especially with crying. Okay. The placenta is removed from fetal circulation, and that's going to be closing our ductus venosus. The umbilical cord is cut and clamped. Wharton's jelly is going to constrict and really close those around those two vessels. Of course, those vessels are two arteries, one vein. Once the temperature does fall, it's going to move from a low resistance to a high resistance. Okay, so pretty much wherever high resistance goes, it's not allowing the oxygen to go there. There's going to be blood in the umbilical vein, and the ductus venosus starts clotting off, and blood flow definitely decreases. This happens in the first few days of life. Okay, number 2, lungs taking in the air. With that first breath, it's going to be pushing fluid out of that lungs, increase in oxygen levels. A lot of changing pressures are going on within the pulmonary vessels. but we have this kind of arrow here. The air pushes fluid out of the alveoli. Fluid enters the capillaries. Oxygen levels rise in the alveoli. Alveoli signal the arteriole to dilate. The arterioles are going to dilate. Lungs are going to go from a high to a low pressure. So it's like going from a system of saying, nope, you can't come here, and it's now to, oxygen come up in here. The oxygenated blood is going to then enter the heart since the resistance in the lungs isn't high anymore. The low pressures cause the foraminal valley to close off within that first few minutes of life, leading to oxygenated blood getting into the aorta. Alrighty, with the closure of the ductus arteriosus, the initial reason blood was going from the pulmonary artery to the aorta was the pressure in the pulmonary artery was originally really, really high. Okay? So it's all about pressures changing. The muscles in the ductus arteriosus are constricting that during the first few hours of life due to sensing increased oxygen in the blood. Prostaglandins that were produced by the placenta are no longer present due to the removal of the placenta. Okay? The ductus arteriosus are closing. It closes when oxygen goes up, prostaglandins go down in the first few hours of life. Prostaglandins are produced by the placenta and keep the ductus arteriosus open. Once the placenta is cut off, prostaglandin levels decrease and signal the body to close the DA. Okay. With that being said, moms should not take NSAIDs during pregnancy. They are what's called prostaglandin inhibitors. So they are cutting off the prostaglandins. And this whole adaptation here is due to prostaglandins being gone. Okay? They are affecting the prostaglandins and maintain fetal circulation. NSAIDs, if given, would close off the ductus arteriosus. This kind of goes into a teaching of in utero, don't take any NSAIDs. But what we can do, because there actually are in pediatrics there are some adaptations that are actually formed because the ductus arteriosus is left open. So what they can do is give NSAIDs after to help it close. And then a patent, so an open ductus arteriosus on a baby that has been born is not a good thing. Okay? So this is kind of the normalization of let's get that ductus arteriosus closed. Okay? But it really comes down to a lot of different factors, and those are going to be in pediatrics whenever it's talking about how if we're needing a way to distribute blood throughout the body that isn't from this, we might be giving prostaglandins after birth to keep the ductus arteriosus open, but for the sake of OB, we do want it closed. Okay. Okay, how's that? Okay, going into liver function. With bilirubin, we have unconjugated and conjugated. Bilirubin is the breakdown of the red blood cells. We're going to be using the words jaundice, kernicterus, things like that in this. When it comes to conjugated blood, it's converted into water soluble. These are supposed to be arrows. They didn't convert from Google Docs. Excretable to direct bilirubin. With an unconjugated, that is indirect bilirubin. The total bilirubin is going to be consisting of both of these. Fetal liver is not ready to conjugate bilirubin well, so it can lead to the, of course, what we call jaundice, which is high, and if it's really high levels, it could definitely lead to neuro damage, kernicterus. Okay. We have two forms of jaundice here. We have physiologic and pathologic. Those words there can definitely kind of help you out. When it comes to physiological adaptations, that is normal. It's normal to turn yellow a couple days after birth, 3 to 4 to be exact. But within pathologic, think of a patho of any bad disease that we've learned about in any past semester. So pathology of this is going to be bad. This is a serious condition caused by a pathologic condition, whether it's an ABO incompatibility or maybe an Rh positive, Rh negative incompatibility. This is seen at birth or within the first 24 hours of postnatal life. Faster than 5 milligrams per deciliter in 24 hours or longer than 1 week, or direct bilirubin of more than 2 milligrams. In healthy term infants, the total serum bilirubin more than 15 milligrams. We have lower levels in the preterm. Of course, too much bilirubin can cause brain damage. All babies can have jaundice, but we do have some risk factors. That being, we're going to talk about this next week, so don't stress about it. Acephalohematoma. And the really good way to match with jaundice is knowing that hemo is blood, and of course jaundice is a breakdown of blood. Maybe it's a delayed cord clamp, maybe it's a breastfed baby, small from gestational age, going on also into small babies, preemies, and definitely sick babies as well. All right, thermoregulation, we're talking about the forms of losing temperature. Okay, newborns really have a risk of being able to lose temperature quick. This will definitely fall into a NANDA, and a lot of the stuff that we talk about here can definitely go into your nursing diagnosis as well. Why is this important with babies? Why are they having problems with thermoregulation? Babies definitely have no fat storage. They have less subcutaneous fat. Their skin is thin. Their blood vessels are very close to the outer layer of their skin. And of course, the temperature does be able to go down at birth. One of the ways they can lose temperature can be through actually evaporation. The fluid comes off the skin, and if the baby gets cold, they're going to increase their metabolic rate. And that, of course, is like a compensation effort to try to kind of help maintain temperature, leading to cold stress. Babies have no ability to shiver. They do have small storages of brown adipose tissue to create heat, but that is very limited. Okay, limited stores of brown fat. They need oxygen to metabolize. So if we have problems with the respiration system, we're going to have problems with temperature control. Wait, that's a big point there. All right, newborn hypothermia. They have higher ratios of body surface area to body volume, lots of space to lose heat. Their heads are very large. They're born they're formed cephalocaudal. So their heads are, of course, a lot bigger, and they are definitely able to lose that heat through the head. That's really why we're putting on those really cute beanies. It's not because it looks cute, but of course it does, but it's to protect them. They have small musculature. They have no ability to shiver. They can't shiver as a way of getting to trying to heat themselves up. They're poorly insulated. Not a lot of fat to provide insulation. They can't say, "Hey, mom, I'm cold," and they really, if there's a cold fan blowing on them, they have no ability to relocate themselves or to pull a blanket over themselves. So it's up to us as nursery nurses to really advocate and take care of them, and teaching as well. It's yeah. And the nervous systems are slow to respond to cold conditions. Cold babies are sick babies. Okay, how do infants lose heat? This picture is amazing. You'll see it on Google. Let's start off by convection. When it comes to convection, we're talking about maybe a flow of wind. The heat is lost to air or fluid around the infant that is cooler than the infant's temperature. Maybe it's air from an open door in the delivery room. Maybe it's you're carrying them to the other side of the room, and that cold air is going really fast over their body, removing the heat, just really stripping it off of them. Okay, Next will be radiation. Radiation is lost. The heat is lost to solid objects near the infant that are cooler than the infant but are not touching. Okay? When it comes to the whole touching thing, not is going to be radiation and touching is going to be conduction. Okay? Within the terms of radiation, this may be from the walls in the room, maybe from the ceiling, anything that's not touching the infant. Okay? All right. Evaporation, of course, love that it's associated with water because heat is lost when water evaporates from the infant's skin's surface or respiratory tract. An example of this would be if you do not dry them immediately after birth. Okay? This is most common loss of heat because it occurs first after birth. So it's really important. We say warm, dry, stimulate, but it's really dry. That really does the job there. And then we have conduction. Think about conduction of electricity and how it's touching. Okay? Conduction is the heat lost to cold surfaces or to objects with which the infant does come into contact with. Maybe it's an examining table. Maybe it's the nurse touching them with a stethoscope on their belly, and that stethoscope wasn't warmed up. So different things like that. A cold stethoscope to us as adults maybe give us a shiver, but a cold stethoscope to an infant can definitely lead to hypothermia. So it's a lot more important for them that we take these measures to prevent. Okay, what can we do? You're going to see in clinicals radiant warmers for initial care. Temperature is controlled by a probe on the baby's skin that connects to the warmer. Of course, when they're on that warmer, they're going to see the side rails. They're going to be up on all sides. That's because we don't want to have any of that wind, that convection going through and stripping the heat off of them. Important things to know with the skin probes: don't lay them on do not lay the infant on skin probe, and do not put that over bony prominences. Do not put them over areas of brown fat deposits. Don't put them over poor vascular areas or excoriated areas as well. Keep the probe exposed to the heat source and securely attached. Why is that? It's because we want to have a correct reading. We want to be able to assess that the baby is really that correct temperature. If it's covered, that probe might be giving off a warmer temperature. So then the baby could be actually over or cold, and it would be a bad thing. Blankets and caps, skin to skin. Mom is normal. Mom is going to have a normal temperature, maybe even an increased temperature. So the fact that her skin and baby's skin are coming into contact can really warm up the baby. Keep the infant dry. Assess their temperature every hour until stable. And the way you're going to do the temperature is you're going to put them in the I would use the term armpit. You're putting right in there. You're kind of closing the arm over that. Reduce the exposure to drafts. We're going to warm any object that comes into contact with the newborn. So when you're doing those assessments and you're in the nursery for a couple hours as a clinical student, make sure you're really taking those measures. Encourage the mother to keep the infant covered when breastfeeding as well. Okay, glucose metabolism. Babies experience an energy crunch at the time of birth with the cutting of the umbilical cord and the resultant removal of the paternal glucose supply. Fuel sources are consumed at a faster rate because of the work of breathing, the loss of heat when exposed to cold, overall doing activity, or the activation of their muscles when they're moving their arms and kicking and everything like that. Newborns have a risk of high hypoglycemia, which can cause brain damage. Hypoglycemia is the main concern, but hyperglycemia can also occur. If you have a hyperglycemic baby, that is a very sick baby. Okay, prevention is really the big thing of this. Be aware of who is most at risk. GDM stands for gestational diabetes mellitus. Maybe they're a large baby, macrosomic baby, or a large for gestational age baby. Babies don't have trouble, or maybe babies who are having trouble with breastfeeding. If it's a small baby, they don't have an extra storage to kind of compensate if the blood glucose drops. Signs of hypoglycemia are going to be jitteriness, cyanosis, maybe apnea, hypothermia, poor body tone, Maybe they're just having trouble feeding. Maybe they're very lethargic, and even seizures as well. The blood glucose, a normal value is 50 to 150. This is done via a heel stick on the side of the foot to avoid hitting a nerve ending in that foot. We're assessing temperatures. We're looking at the tones. We're doing frequent assessments. We're keeping them on a feeding schedule. And really, we're going to talk about how much we're feeding in the next couple slides. Interventions, food, regular feeding, IV fluids if the food is not working. When it's talking about feeding, we're going to talk a little bit about how feeding is more present when you see that the baby is wanting to be fed. It's not really like a timer, like assessing vital signs or anything like that. Okay. I apologize. Okay, coagulation capabilities of the newborn. A need for vitamin K unless declined by the parents. This helps initiate clotting factors that aren't in the gut at birth, and we're giving IM in the vastus lateralis. They have a huge risk for bleeding and coagulation problems if we don't get this vitamin K, so we're having to teach. Have to be cautious about finger sticks, newborn screens, pulling blood, things like that. Baby boys cannot get circumcised if they don't have that coagulation to kind of clot off that blood. The oral isn't as effective, but it has to be taken for a longer period of time than just a simple intramuscular injection. Okay, immune function. When it comes to the overall immune system, of the three major types of immunoglobulins, that being IgG, IgA, and IgM, it's only IgG that crosses the placenta. Therefore, the infants receive a passive immunity from the mother in the form of the IgG near the end of gestation, also called frequently, as it's here, passive acquired immunity. The infants eventually produce antibodies, though, called active acquired immunity, beginning at about 3 months, and this is with IgA. But IgA is missing from the respiratory, urinary, and gastrointestinal tracts until about 4 to 6 months, unless the newborn is breastfed or until infants produce their own antibodies. Infants who are breastfed and provided antibodies from the breast milk for as long as the mother chooses to breastfeed are provided that protection from many diseases, including the flu, mumps, and chickenpox. Okay. Really, that's a really good summary of that. But of course, IgA is giving through breast milk. So really, a lot of teaching can be. A lot of teaching is within, talking about how it's not just feeding, but it's also, you have lots of antibodies and that you actually can kind of pass on to your baby. Okay, that's what we'll do with that. Okay, next page right here. Okay, within infections in newborns, this is subtle because the system is developing over the first year of life. Infection in newborn could cause an increase or a decrease in temperature. A lot of times it can be cold, maybe a decrease in white blood cells. They'll have maybe abdominal distension, maybe even the system's not functioning, the decreased urine output. We have to assess differentials. If mom has symptoms of infection, you need to watch for babies' signs of infection. Within preemies, we have to start treating them immediately. You might ask why we have a decreased white blood cell count when with adults it's always an increased level. That's because the baby's circulatory system is immature at the moment and it's slower to respond. All white blood cells are being sent out to fight an infection, therefore they're going down. Now I'll talk about sepsis within the newborn. I'm pretty sure we're going to go over this in high risk, but it doesn't hurt to kind of talk about it more than once. Within sepsis, this is this is an infection that has gone through the bloodstream, of course, The patho of this might be from an immature immune system, the inability to maybe localize an infection, or they lack the IgM, immunoglobulin, which is necessary to protect against bacteria, and the IgM does not cross the placenta. When sepsis is suspected, we're going to, of course, just like how we do adults, we're going to be doing a culture, and then we're going to start antibiotics immediately. After 72 hours, sorry guys. And then after 72 hours, that's when we're getting more, for sure, we're getting more defined. And antibiotics that were there before may be discontinued if a final culture is negative, or maybe they are able to go into the, of course, just get into the more precise cultures or antibiotics as well. The risk factors of this may be from a prolonged rupture of membranes, so more than 24 hours or something like that. Maybe it's a very long labor. Maybe they needed invasive measures. Maybe the mother had a maternal infection. But I would say for the test, focus on symptoms, okay? Symptoms can be really vague. That's a very good term there. Temperature instability, especially within the newborns, hypothermia. The feeding intolerance could be evidenced by they're just not eating. They have a decreased intake, of course. Maybe they have abdominal distension. Maybe they're vomiting, or maybe they're just not. They're having poor sucking reflexes. They might have subtle changes where just the nurse or the mom just thinks the infant just doesn't look right at the moment. They might be lethargic. They might be slightly pale, or having seizures. They might have a progressive respiratory distress. Their bilirubin levels might be high with hyperbilirubinemia. And they might even have tachycardia initially, maybe followed by periods of respiratory distress apnea and bradycardia. All right, immunizations. It's important for mom to be up to date on their shots. We have TD. This protects the baby from neonatal tetanus. The umbilical site is the entry of bacteria. Starting at birth, we're going to give them Hep B, protecting against maternal Hep B, preventing devastating chronic contagious illness of hepatitis B. The next set will be at 2 months, and as early as 6 weeks. Example for a baby with sickle cell to get some early protection. The CDC does provide all up-to-date records. No live viruses until the first year to get the best response. I would say for your test, know which ones are live and which ones are unattained, especially MMR. If there are any specific considerations for any vaccines, know those. You don't need to know the immunization schedule yet. That's going to be pediatrics. So don't stress on that yet. Okay. Going into our torch infections. This is... Oh, I'm sorry. Okay, with torch, obviously, the T is going to be toxoplasmosis. This is contracted by eating raw or undercooked meat or contact with feces of infected cats. This can be found even in garden soil, and this is a maternal transmission during their pregnancy. This often results in a spontaneous abortion if contracted during the first trimester. And interventions of toxoplasmosis will be using effective hand hygiene, avoiding eating raw meat, avoid being exposed to our cat litter, garden soil, or any uncovered sandboxes. Kind of odd. You can have the toxoplasma titer checked prenatally if cats live in the household or if a cat is an avid gardener. Okay, with the H, the O stands for other infections, but it's usually going to be hepatitis B. Hepatitis B is transmitted from the mother to the neonate in about 90% of those cases. The infants of the mother with a positive hepatitis B surface antigen should receive the hepatitis B immunoglobulin. That'll be an intramuscular injection within the first 12 hours of life. They should also receive the hepatitis B vaccine with the first dose within the first 12 hours of life. The second dose of that vaccine will be given at 1 month, and the third at 6 months. Okay, when it comes to the R, that's going to be rubella. This is also called the German measles. Up to 20% of women of childbearing age are not rubella immune. That's why we have the rubella titer. And remember that number is 1 to 8. So if the titer is 1 to 8 or greater, this indicates that the mother is immune. Okay. About 90% of fetuses exposed during the first trimester will be affected either by spontaneous abortion or congenital anomalies. Okay, with C, that's going to be cytomegalovirus. The cytomegalovirus is a respiratory or sexual transmission, and the neonate can actually contract this during delivery through the infected birth canal. Most common causes of this infection are from a viral infection. Most of these are asymptomatic at birth, but they may experience, anemia, jaundice, hemolytic issues upon later. And if they do have CMV, cytomegalovirus, that can be progressive through infancy and childhood. Okay, last one. We are at H now, being herpes simplex virus. This could be type 1 or type 2. You're going to learn about this in MedSurg, but the symptoms of this are maybe vesicles on genitalia, thighs, their butt, and they may be actually usually painful as well. Fetal symptoms of this may be including a fever or hypothermia, so either or. They may have jaundice, they may have some seizures, poor feeding, and up to 50% develop vesicular skin lesions. There's no known cure. The virus can be lethal to the fetus. That's why if they have any active lesions, we will be doing a C-section. And maybe depending on providers, even if it's not active, they still may want to do a C-section as well. Okay, that'll be that. Okay, breastfeeding considerations. Bottle-fed babies are at an increased risk for infection. There's no colostrum, there's no antibodies being given to the baby. If mom gets sick while nursing, it's important to keep nursing. Moms build antibodies and give them, they're giving those antibodies to the baby and therefore protect the baby. Can the moms use drugs during breastfeeding? No. Can moms with, moms that are often common having a poor milk supply, maybe hypertension patients, diabetic patients, contraindications for breastfeeding are going to be active untreated tuberculosis, galactosemia, of course, any illicit drug use, alcohol use, and cancer drugs, so methotrexate. Within breastfeeding considerations, I would say infants really don't, well, they do. Infants regulate their own intake of breast milk and control the breast milk production. Okay, scratch that. The breast is never really emptied. It's really just how much the infant chooses to intake. They control whenever they want to stop. Okay, that's pretty much that. A schedule shouldn't be imposed on a breastfeeding newborn, as they have a stomach capacity of about 30 milliliters, and breast milk is more easily digested than artificial milk formula. Breastfeeding infants should be fed when their hunger cues are displayed. Those hunger cues are going to be rooting reflexes, sucking on fists, clenched fists. These cues may be exhibited from 90 minutes to 3 hours after the last feeding, and crying is the last sign of hunger. Night feedings will be necessary during the first 6 to 8 weeks, so that's pretty important. And research actually doesn't document that the common myth that limiting time at breastfeeding or limiting time at breast will prevent or minimize sore nipples. Sore nipples are almost always caused by the actual incorrect positioning of the infant, or maybe it's a really poor latch. So if they're thinking, I want to do this less to prevent soreness, that's maybe more a latching issue. Mothers should watch their infant, not the clock. When an infant is doing at breast is at better, and what an infant is doing at the breast when they're skin to skin is a better indicator of milk transfer than the actual amount of time spent there. So don't say, hey, I'm only going to do this for 30 minutes. It's really whenever the baby wants to stop. Okay. All right, so you'll see this in clinical, but there is a gestational age assessment. It's frequently called the Ballard assessment scale. It's a huge sheet that you're probably going to fill out for fun, and you can even get the nurse to teach you. So please feel free to just ask them, hey, can you show me how you kind of do this? Because those nurses are experienced. They do this. They do multiple parts of the Ballard all at one time. Okay. This is really used to kind of document and figure out what percentage they are on their gestational age. They could be small, they could be large. You'll probably see a picture in class where she'll show you two babies who are the exact same age, but they may be large or smaller. And it's crazy because you could have a baby that's the same age as another baby, but one looks like it's a preemie, or one looks like it's a very big baby. So don't commonly associate preemie with small. This is really showing that it could be different causes. Of course, we have the terms here that go back into our old exams. Preterm is anything less than 37 weeks. Term is 38 to 41. Post-term is more than 42. We do have the SGA, small for gestational age, is when they're less than 10% of the curve. 10 to 90% of the curve is the average, and then if they're more than 90% of the curve, they're deemed large for gestational age. The gestational age less than 37 weeks gestation is based on due date. When we're doing a quick assessment of the fetus or the baby, the due date is unknown. They're gonna be able to do a really quick assessment. So for example, when you're looking at the newborn, if you see creases on their feet, the creases cover a third of the soles of their feet starting at 36 weeks. If they have breast buds, that comes into consideration because breast buds are absent until 37 weeks. The ears, their cartilage, that ability to spring back, the ear cartilage has pretty much no recoil until 30 weeks gestation. Vernix caseova will cover the body by 31 weeks to 33 weeks. And then lanugo will cover the shoulders by 33 weeks to 36 weeks. Okay. This is the picture of that Ballard. The Ballard is an assessment that it's going to look at their neuromuscular and their different physical characteristics. A score of 1 to 5 is assigned to each characteristic, and a total score correlates to a gestational age. As example, a term newborn given a score of 3 for every characteristic on this list would get an average 18 for a neuromuscular assessment and an 18 of a physical assessment. The total of that would be 36 points. And a 36 point will correlate to 38 weeks of gestation. The numerical rating is then marked on the graph, this graph right here. Yes, this graph right here. With the newborn's birth weight, their length, their head circumference, to classify the newborn based on maturity and intrauterine growth. An overall rating of below the 10th percentile indicates the infant is small for gestational age. If it's between 10 and 90, they are appropriate for their age. And if the infant is above the 90th percentile, then they are deemed large for gestational age. While we're doing this assessment, it's important that we're wearing gloves when assessing the newborn after birth prior to their first bath. Okay. As a consideration, if we have maternal conditions, maybe the mom has preeclampsia, diabetes, or she took a lot of maternal analgesics or anesthesia during the intrapartum period, this actually may affect some of these assessments. Feeding and weight. 10% of a weight loss from birth is seen in the first week of life, but will return to that birth weight by 2 weeks. In your book, or in my old book, it says it takes 7 to 10 days to get back to the birth weight. Okay. You're going to initiate feedings, breastfeeding or bottle feeding. Start the breastfeeding as early as possible. This will release oxytocin from the mom to stimulate uterine contractions, and what uterine contractions are going to do is, of course, prevent postpartum hemorrhage. Any infection the mom has is transmitted through the breast milk. Standard formula in breast milk is about 20 calories per ounce. Breastfeeding on demand. Formula feeding. The first few hours of life, no more than 1 ounce at first. After the first few days of life, 2 to 3 ounces of feeding every 3 to 4 hours. Do not force feed the baby. Breast milk that is freshly expressed and not refrigerated is good for a few hours. Breast milk is good for a lot longer than formula because it is bacteriostatic, meaning that it has good bacteria and keeps the bad bacteria away. We do perform a hearing screening on our newborns. It's supposed to prevent any, of course, hearing problems that develop later in life. If the baby was to have a hearing problem, that leads to cognitive disabilities as well. We're going to use brain waves. We're not going to ask them if they hear it, but we're going to use brain waves. We're going to put them on their head, and then they have some really cool headphones on, and we're going to see if the baby is a positive screening. We want the baby to be in a calm environment. So when I was in clinical, I saw that the baby was crying, and they actually had to delay the screening. If the baby fails this hearing screening, they're going to repeat. If they fail again, then we're going to do a consult. This is meant to catch and treat anything early. We're going to prevent developmental delays, improve their overall quality of life, and of course prevent, even if it's something very bad, this will be even preventing death if we can get it early. Babies don't talk until they're 2 years old, so if you can catch and fix the problem of not being able to hear, this will very much help their speech significantly. Okay, they are going to get a newborn screening for all of these things here. This is done before discharge on every neonate but regardless of age or feeding status. This is mandated by the state, just because we have to check for any of these metabolic diseases. I would say this slide's just write down what we have here, and that's what I would say. We have hypothyroidism as an example. The longer the baby's hypothyroid state, the more brain damage definitely can occur. Okay, congenital heart defects. This is an important topic here. That's what I've highlighted. CHDs can be taught early via ultrasound if mom has good prenatal care. You have to catch congenital heart defects before they go home, because some congenital heart defects are ductal dependent, that being the ductus arteriosus. And once that ductus arteriosus were to close, then no blood will be going to the rest of the body. Therefore, they won't survive. So we have to do this. We're going to be doing a test here, and we're using the terms preductal and postductal because we're comparing the two. Preductal, you're going to be putting a pulse ox on their right hand. Less than 90%, we're going to, of course, get cardiac. 90 to 95%, we're going to compare to the rest of the body. Okay, if it's greater than a 3% difference, we're going to repeat that test in an hour, and we're going to do that 3 times before we will consult cardiac. Less than 3% difference, we're going to move on. Postductal, we're looking for, of course, that greater than 3% difference. Sometimes it might be the right hand and the right leg. Okay, if it's positive, we have a potential congenital heart defect. If it's negative, no possible congenital heart defect. Make sure you keep moving the pulse ox probes to prevent burns on the baby. And Harold might show you a picture of what that can do if you leave one on a foot for a really long time. This is a chart of exactly what that was. So if the child, we're doing an assessment. We have these different ways to get to these different results here. So if we get more than 90% on the right hand or foot, then it is a positive screen. Less than 90% on the right hand or foot. That would always go to the positive screen, being that we need to consult cardiac. If it's a more than 90% in the right hand or foot and a less than 3% difference between that right hand and right foot, less than 3% is a good thing, so that would be a negative screen. We have these different repeatings because if it doesn't match, we're going to do it again, and then we're going to do it again. Okay, in the middle one here, if it's 90 to 95, if it's between 90 and 95% in the right hand and the foot is more than a 3% difference, that would warrant a positive screen as well. So that would not be a good thing. Eye prophylaxis, erythromycin. Look up the trade name as well for this in case he was to put that on there. This is used to prevent gonorrhea and chlamydia. We're instilling this in the lower conjunctival sac, starting at the inner canthus. This is a ribbon-like strand of ointment that's kind of given, and we're massaging the eyelid gently. This can be delayed up to 1 hour. So sometimes, if it's a C-section and we're doing lots of assessments, we might be doing this, of course, an hour later. This is usually done. What I've seen, it's during the process of which they are doing the whole weighing and things like that, and of course giving vitamin K, things like that as well. All right, newborn care. Within the normal, the young female, we might have pseudo menstruation. So if it's normal if there's any blood there. Of course, we're wiping front to back. We're going to be doing diapering. We're doing warm, of course, warm to prevent any cold. They're warm water wipes. We're not doing any powders. We don't want to aspirate. We're cleaning. Not too sure if we actually are cleaning milk or wort with an alcohol wipe. I don't really remember that. But warming the water on the face. No soap, no lotion, no baby shampoo for hair. Within the circumcision, we are cleaning with soapy water. you see a question ever saying that you're cleaning a circumcision with alcohol, that would be incorrect. We're assessing for bleeding, edema, and if they're able to void, that it was correct. With an output, we're counting wet and dirty diapers. That's our number one way to observe feeding, is the wet and dirties. So when you're hearing an assessment, you're going to hear wet. They're going to say, we had 6 dirties, 3 wets. Well, that would be the opposite. They would probably have a lot more wets than the dirties. Yes, because peeing is more frequent. Okay. Bracelets are put on the child really to prevent any abduction. It's just a safety measure. As soon as they're born, we're putting a bracelet on the mom and the baby, and of course, and whoever the mom wants to put it on also. So it could be a grandmother, it could be their partner. We're doing formula feedings. If they are doing that, we're teaching them, do not heat the bottle and the formula in a microwave. Just think about when you're putting a thing of soup in the microwave, and it's all. Sometimes you get a cold chunk of soup. Sometimes you get a really, really steaming hot chunk of soup. The real reason is we don't want to prevent. Of course, what we think is hot is different than babies, but they won't mix. It's not gonna. Of course, it's just not safe. It needs to be in warmer. Formula is only sufficient diet for the first 6 months, so we're not giving them cow's milk. Within breastfeeding, we're looking at the ability to latch. Teach mom how to pump breast or store breast milk if needed. Breast milk only is sufficient for the first 6 months. With bathing newborn in a warm robe before feeding. Use a mild soap, not on the face. Clean the eyes from the inner canthus outward, and of course, dry that baby. Within clothing, we're teaching them that their head needs to be covered. Do thick layers for cold weather. I was taking OB during the freeze, and I just worried for the babies that were born that I saw in clinical during or right before the freeze, because I was just thinking, oh, these people might have lost power, things like that. With cord care, we're doing the umbilical clamp. That can be removed after 24 hours if the cord has dried and, of course, clotted off. We're cleaning using soap and water. We're folding the diaper below the cord. The newborn is washed a sponge bath until the cord falls off within that first 2 weeks. Home care should emphasize on keeping the cord stump dry and clean. The areas should be exposed to the air or covered with loosely clean clothes. With our uncircumcised newborn, inform mom that the foreskin glands are 2 similar layers of cells that separate from each other, and that the separation process normally is completed by 3 weeks. Do not pull on the foreskin. That would be very, very harmful towards that infant. But we have to allow them to have the natural separation to themselves. Clean the foreskin glands with soap and water for cleanliness. With parent education, our mothers have to have a car seat in order to be discharged. Sometimes fire departments or different safety organizations will actually provide different car seats. We have to make sure that it's put in the car correctly. It should never be put in the front seat. The safest spot is in the middle, facing the back. So that back row of a car as well. And we're also doing teachings of when to call the doctor. If their temperature goes above 104 or below 36 C axillary Celsius, that would be just either too high or too low. If they have a continuous rise in temperature, if they're more than one episode of frequent vomiting in 6 hours, if they refuse 2 feedings in a row, if they're lethargic and difficult to arouse, maybe they're cyanotic with or without feeding, maybe an absence of breathing for more than 20 seconds, a continuous or unresolved high-pitched cry that would be different than a normal cry. Maybe they have no wet diapers for 18 to 24 hours, or maybe they have harmful eye drainage as well. We're going to be going over the newborn physical assessment within my next video.